Welcome to The Skin You're In, a podcast about health and the forces that shape it. We go beyond medicine to explore how race, place, policy, and culture influence who has the opportunity to live a healthy life and what it will take to achieve health equity. From data to lived experience, from public policy to music and the arts, we connect the dots between systems and stories. Because health doesn't happen in isolation. It's shaped by the world around us and the skin we're in.
Hello, and welcome to the Skin You're In podcast. I'm your host, Thomas Levis, Dean and Weatherhead Presidential Chair in Health Equity at the Tulane Celia Scott Weatherhead School of Public Health and Tropical Medicine, and Principal Investigator of Partners for Advancing Health Equity. I'm also the writer and director of the documentary, The Skin You're In, and I'm excited to introduce today's guest, Dr. Georges Benjamin. Dr. Benjamin is a physician and the executive director of the American Public Health Association. He is recognized as a prominent health policy leader, practitioner, and administrator. Prior to joining APHA, Dr. Benjamin was Secretary of Health in Maryland, where he oversaw the expansion and improvement in the state's Medicaid program. Today, Dr. Benjamin is known as one of the nation's most influential physician leaders who speaks passionately and eloquently about the health issues having the most impact in our nation today. We're honored to have you today, Georges.
Tom, thanks for having me.
You know, you've had a long career in public health, but you've had some really hard jobs. You were Washington, D.C.'s health officer, and you were a health officer in Maryland for 9/11. You were at APHA for Katrina, heading up APHA during DOGE. What have you learned over the years dealing with these crises?
You know, all of these various crises that we've had, kind of like working in an emergency department, sometimes there are real challenges and sometimes they're not, and I've learned how to triage, to figure out what's important and what to focus on first. And at the end of the day, trying to improve the health of the public is the goal. And so I try to, line up everything to achieve that goal.
But is that different during a crisis or on a day-to-day basis?
Yeah, in a crisis, you have to figure out, as you say, which person is going to die in your emergency department waiting to be seen. It usually isn't the one that is the crisis right in front of you. It's the one that is sitting there lurking that doesn't look like it's a crisis. So you have to address the one that's there in front of you, but you also always have another eye looking at what's going to be the next crisis that's happening. What's the one that's happening that you haven't thought much about? I remember 9/11, while we were all worried about, the airplanes that hit the World Trade Center and the Pentagon, and there was all these concerns about what attack will come next. A month later, we had no thought that somebody would have used that timing to send anthrax to the mail. In fact, we didn't even think you could, the average person could refine anthrax. Of course, it turned out it was someone who was an expert at doing it, but we never even thought that would be an issue for us, but it turns out it was a big issue.
So I've noted that in these leadership roles, you've been, and sometimes you've been in government, sometimes you've been outside of government. Where have you found that you can have the most effect?
I'm an action guy, so I certainly like to have my hand on the wheel, my hand on the football, as they say. So I love to be in government in terms of actually making things happen because in many ways, being an advocate is good and wonderful, and you can influence a lot, but actually being the person that makes it happen is very appealing.
So what are those tools? The tools for making it happen from an advocacy standpoint. In other words, as executive director of APHA, where do you have power? Where do you have perceived power? And where do you maybe not have as much power as others might think?
Well, APHA has always been more influential than our size, our budget has given one the impression that we should be. So we've always had in many ways, an outside influence. Part of that's because we're over 150 years old. Part of that is because, my staff, my members have seen stuff and we can rely on that. But there are many people who think that we have the billion-dollar budgets that the Heart Association and the Cancer Society have. And when I got there, our budget was $12 million. It's now about $25 million. They think that there's 1,000 staff people under our roof. There are 75 of us. So we do have more influence. But I think it's focusing that influence on the things we think are important. Trying to focus on a few things that we can think make an impact, and recognizing what our role in this enterprise is. Our role is that we're not going to be the group that's going to put together a program that's going to make people happy. But what we can do is we can help build the capacity of the field to make people healthier. And so we focus like a laser on helping build the capacity of the field to do its work.
So when you say make people happy, what do you actually mean by that?
Well, make people healthier. I've always talked about life, liberty, and the pursuit of happiness. I think those are fundamental to getting up every day and doing what you do and feeling well. So at the end of the day, we're trying to, through what we do, help the field build this capacity to make sure the air is safe to breathe, the water is safe to drink, that when you get up and you move from one place to another, you're not going to be injured by something that's preventable. Give people the assurance that life can be grand if you do things that can give you longevity. We work very hard to do that.
Yeah, so when you said happy, I thought what you were talking about was from a political standpoint. We in public health, we talk about evidence-based, and we try to use this, we talk about the science guiding kind of where we go. But there is ideology. There are political perspectives that are dominant in our field, aren't there?
Oh, absolutely. I mean, we all bring biases to the table. We all bring our life experiences, our upbringing. It drives what we think, what we do, what we think is valuable.
Yeah, but each individual, but there are dominant political ideologies in public health.
Yeah, they are, but I think we'd be fooling ourselves to think that public health has one ideology. Half my members live in conservative states. And while some of them may be more progressive in some areas in terms of things they think are important, but there are things that they do. So, I mean, we are very much as an organization by policy pro-choice, but that means tolerating and accepting pro-life individuals. Pro-choice means that. We have members who want to be very proficient at telling people that gun safety is a very important thing. Firearms are a leading cause of death of young people, and yet I've got members who have firearms. They're hunters. They live in the South. They value the Second Amendment as a core principle. And so if we begin looking at people and thinking that everybody thinks alike and thinks the same, we'd be fooling ourselves. Now, I think everybody in public health believes that it's important to improve the health and well-being of the population. And I think most people in public health believe that doing it through fundamental policy work is a very efficient way to do it. But we have a lot of people in public health that still do clinical services, that still see their core role in public health is laying hands on patients, making sure they get health care and providing that care directly. So it depends on where you are.
So for much of what's been happening over the last year or so, this administration with the DOGE and the programs that were eliminated from the federal government, APHA has been the tip of the spear in sort of fighting for funding for public health. Talk a bit about what you've been doing.
Well, we worked in a very collaborative manner with the Trump 1 administration, and then of course the Biden administration afterwards. But towards the end of the Trump administration, many of the things that they were doing were more blatant. We saw a lot of illegality happening, things that we thought were inhumane, such as the parental separation policy the administration had. And we knew that we were going to have to take, should Trump be reelected, a much more assertive role as part of our activities. That we would still try to find ways to work with administrations because we're nonpartisan, but that our fundamental goal was to help improve the public's health. So tragically, when this administration came in office, they began doing a lot of very destructive things in an indiscriminate, in our minds, illegal manner. So for example, when DOGE came in, we knew that DOGE was illegally constructed. It did not follow the Federal Advisory Committee Act on anything that it did. You know, most of us who've been on federal advisory committees know the exhaustive vetting you get done for your conflicts of interest, both financial and personal, that there is a charter that has to be followed for your creation, that you have to be a federal employee, and that, yeah, this whole idea of special government employee is an interesting way to engage people, but it doesn't take away the responsibilities of the career staff. So you have a guy comes in and he just starts indiscriminately firing people and not even understanding what they're doing. I'll give you an example. The day they came in and fired all the people who were in jobs that were not, they did not think were permanent jobs. And that included a lot of the EIS folks, probationary employees, they called them. But it turns out in the federal government, a lot of people who are career, people who are in well-supported training programs like EIS, are considered probationary employees during that time period that they're in there. And then they eventually, get solidified into jobs. So they, in effect, fired all these folks thinking they were, in effect, doing what they did in the private sector, getting rid of people who were early in their career in government and would be easy to fire. Well, it turns out that's not the case. And in effect, they fired was the equivalent, when they fired these EIS folks, they were firing the equivalent of the Navy SEALs for public health. Didn't know that. So we called them and told them that. And then media called them and told them that, and they brought them back. But they've done so many things in an indiscriminate manner. So the point is, we've found new tools, and the tool we've most aggressively used has been suing them, going to the courts, getting restraining orders, telling them, filing amicus briefs, and letting them know where they've broken the law. And so far, we've been reasonably successful at getting grants back, getting some funding back, getting some employees back. But it's a big task because so many things they're doing that are random and illegal.
Yeah. And that's the plan. You kind of flood the zone with so many things that so many different, to be able to organize to respond to every issue that comes up just becomes difficult.
Yeah, well, the beauty of the flood the zone strategy is that it only works if you don't know how to triage. Mm-hmm. And so there are many things that the administration is doing that just drive us nuts. Certainly, I get up and say, oh, no, they did that as well. But we've tried to stay focused. We've tried to stay focused on things that we think impact important fundamental things: people, money, infrastructure. So we have tried to work with Congress to make sure that funding has been restored. We try to work with the courts to make sure that we pointed out the illegalities when they've done things. And again, that's resulted in some restoration of infrastructure. So a lot of what they've done has been more media, has been more seen in the media, and they've been less successful than one would actually think by the actions that they've tried.
But it's also our responsibility to work cooperatively with government where there are opportunities to do that. So have you found opportunities with this administration, within the MAHA movement?
Well, the other day we put out a press statement supporting the administration's efforts at EPA, who I might add, the week before we had sued on the particulate matters issue. But we supported them on going after plastics in our environment and microplastics in our food. We think that's a worthwhile endeavor. Question is how they're going to do it, but we think the idea is a worthwhile endeavor. We have, looked to work on the research side with the administration on where they want to do research. Of course, we've adamantly opposed their attacks on diversity, equity, and inclusion, which we think are immoral, I would argue racist, and driven by a negative ideology about what DEI actually is.
I'll talk about DEI. What are the benefits of DEI? Why should we be doing it?
Well, we got to think about what it is. So diversity, equity, and inclusion, and my staff would add accessibility to that. And I would argue that if you're not for diversity, you're for homogeneity. If you're not for equity, you're for inequity. And if you're not for inclusion, then you must be for exclusion, okay? Diversity means making sure that everyone has the opportunity to be involved, that we know that diversity results in a whole range of societal benefits when you bring together a diverse thought process, people, and engagement. Equity is important because it's an ultimate goal to make sure people can achieve their optimum health. And inclusion, basically, if you think about it, what inclusion means is simply asking who's not in the room, who should be brought in, whose viewpoint are we missing? It's a fundamental question that we should always be asking ourselves. And as you think about this, they've decided that diversity, equity, and inclusion is reverse racism, which it is not. It never has been. It's never been practiced that way. And yet they try to make that, a negative thing. What's disappointed me is a number of our well-learned institutions, both on the legal side and on the academic side, that have run for cover. That tells me they weren't committed. So we at APHA said, we're not changing our language. We're going to continue to support diversity, equity, and inclusion. Equity is the fundamental of human life and value. And we think that it's important. And so we've stayed with that. The American Journal of Public Health, same thing. We're not going to tell other people what to do. We're not going to tell other people they can't change their papers, but everything needs to follow the evidence and the science. Otherwise, we're not going to get there. Now, as you know, we worked together on several projects with the National Academy of Medicine. And one of those where we looked at health equity, there was the unequal treatment report that was a little over 20 some years ago. And then we got a chance to relook at that on its 20th year anniversary and discovered that we've learned a lot about what the causes of health inequities are, but we haven't implemented a lot of it. And we haven't done much to actually accomplish closing those equity gaps, those outcome gaps, where you have them, and primarily driven by people in underserved populations, people of color, African Americans, Hispanics, Asians in some cases, not always, but in some cases. And that there are tools that we can do to address those and that we're not using.
Why aren't we?
A lot of them are structural racism issues, frankly. The society is constructed. There's always somebody who benefits when something disadvantages another person. So money, resources. Some of it is not conscious. A lot of it's not conscious. It's just the way the system's been set up. But it's set up to benefit somebody, and therefore it may disadvantage others. And so we have to change fundamental societal structures that benefit others. And then, of course, you have the long history of benefit for some populations. Lots of us, if you're a first-generation college student, you're not going to have the benefit of your parents having gone to that school. But if you're a second or third generation person, your parents went to a university, you're benefiting from them having the experience of higher ed, and you will benefit sometimes from them having gone to that school where the school gives a benefit to, prior graduates' kids. And yeah, that happens a lot. And we know that happens. Is it wrong? I don't necessarily know that it's wrong, but it certainly is something that one should acknowledge is an advantage for those students. We should work to try to make sure that it's okay for those students to get in, but who are we leaving out? Again, sitting at the table saying, okay, we have our legacy kids here. Who are we not letting in who have the capacity to do well in our school, who meets the kinds of students we would like to have at our school, and how do we get them in there? And That's what diversity, equity, and inclusion programs, that's what some of the minority health programs did. In fact, it turns out that if you actually look at who benefited from many of the DEI programs, it turned out it was white women. Benefited a whole lot because what it forced us to do was say, okay, wait a minute, there's not enough women in this class. Why are these qualified women not at the table? And so we went out and they found highly qualified women. Quite often they were minority women, often, and who were not being included, particularly in medical school. And now we're seeing more and more African-American women, for example, going to medical school. My class in medical school, they made an urban health program at the University of Illinois, made a concerted effort to find people who had various life experiences who they thought would do well in medicine. Good grades, but had done other things in their life which gave them, based on their experience, that they would be able to handle the rigors of medical school. Medical school's a rigorous program. And just because you're real smart doesn't mean you're going to be a good doctor.
Mm-hmm. So for those of us on the academic side, preparing the next generation of public health leaders, what advice do you give us? What should we be telling these students to help prepare them for this uncertain future?
Well, life is very uncertain. My pathway through medicine into public health was certainly not planned. I did not sit down, although there are people that do sit down and plan their careers and they map them out and they're successful at doing that. Mine was very much a maze to getting to where I was. But what I tell them is make sure that those students, you get good people that both have the academic capacity to do the work, but who are committed to the mission. And particularly in public health, they have to be committed to the ultimate goal of helping everyone achieve optimal health. And that's a moral imperative, that this is not a 9-to-5 job. It's not a 9-to-5 Monday through Friday job. It's not a remote job either, by the way. I know everyone wants to stay at home and work from home, but it's not a remote job. You've got to get out in the hood and you've got to be comfortable talking to people and you got to be comfortable engaging people, and that's the job. The job is, even if you're doing high quality research, you've got to get out into the community to understand why people do what they do. Far too often we've had researchers saying, I have the solution to obesity. I'm going to get people to get out and walk more and eat more healthy and maybe even, go to the gym every now and then, But when you go into the community, what you discover is there are no sidewalks, there's no place to play, the playgrounds are dangerous, they don't have money for a gym, and after working 2 jobs, trying to convince them to not eat high salt, high fat, low nutritious food when the only thing in their neighborhood is that, giving them a dietary counsel is not the solution. So you've got to figure out how you as a public health person are going to help make that community walkable, bikeable, green, with access to fresh fruits and vegetables. And by the way, that usually doesn't happen without phenomenal policy change, by dealing with zoning laws, by talking to public officials to try to make sure that someone can benefit from putting a grocery store in the hood. If you can't make money putting a grocery store in the hood, then you're going to make money with a small bodega selling tobacco and alcohol to make your margin. That's how you're going to make money, because you got to survive. That's a business. And so you've got to know that, and it means you got to go in the community to see that and understand that.
So P4HE, we bring people together from multiple sectors of society: government, higher education, or education, civil society, and private sector and philanthropy. You've just talked about most of those areas, but talk a little bit more about the private sector. When you engage with the private sector, what's your messaging around health, producing a more healthy population?
I encourage all my public health colleagues, the health officers, to join the Chamber of Commerce in their community and participate in the business of the chamber. We're a member of the chamber in Washington, D.C. Not as active as we need to be, but we're there. And to make sure that people understand that health is a business. In many communities, the hospital is the largest employer in town. If it's not them, it's the medical school or university. And so they're a major employer. That means they have enormous influence on policies and things like that that happen in the community. And so you can be a trendsetter. You can not only simply provide services, but also you can help create the environment for people to be healthy. So for example, we know that liquor store density correlates pretty high with not only alcohol use, but other behavioral issues, particularly mental health problems. Dealing with zoning, going to zoning hearings and spending some time talking about what should be zoned in the community.
When the history of this era of public health is written, what do you want the entry about APHA to be?
Oh boy, I want people to think we are a fair and neutral arbitrator. You know, that we will focus on the health of the public and that they recognize us as having made a difference. I think that's going to be extraordinarily important for our history. We believe we've been that through the years. You know, as you know, sometimes we've been viewed as being far to the left. We've never been viewed as being far to the right. But I just want people to think that we're an honest broker.
Well, George, just thank you for joining me on the Skin You're In podcast. It's always a pleasure to talk to you.
Tom, thank you very much for having me.
Thank you for joining us for this episode of The Skin You're In. Be sure to visit our websites, tsyi.org and partnersforhealthequity.org. That's partners, 4, healthequity.org. Follow us on your favorite social media platforms. And be sure to subscribe wherever you enjoy your podcasts. This podcast is brought to you by Partners for Advancing Health Equity, which is led by Tulane University Celia Scott Weatherhead School of Public Health and Tropical Medicine, is part of the Tulane Health Equity Institute, and is supported by a grant from the Robert Wood Johnson Foundation. Until next time.